Knowing is not enough, we must apply. Willing is not enough, we must do. Immunology of hematological diseases, immune hemolytic anemia, autoimmune neutropenia, immune thrombocytopenia, pure red blood aplasia, aplastic anemia, BNH, lymphocytic leukemias, lymphomas. Immunological mechanism affect hematopoietic precursors, proliferation of the primary cell of the immune system. Immune hemolytic anemia is some slides of the under the microscope. Immune hemolytic anemia, all required antigen antibody reaction, types of reaction dependent on the class of antibody, number, spacing of antigenic site on cell, availability of complement, environmental temperature, functional status of the reticuloendothelial system, manifestation, intravascular hemolysis, extravascular hemolysis. Antibodies combined with RBCs either activate complement cascade or opsonize RBCs for immune system. If all of the complement cascade is fixed to red cells, intravascular cell lysis occur. If two or more, if complement is only partially fixed, macrophages recognize FC receptor of Ig, of C3p, of complement, phagocytose RBCs, causing extravascular RBCs destruction. Looks for immunoglobulin or complement of surface of red blood cells, normally neither found on RBC surface. Combs reagent, combination of anti-human immunoglobulin, anti-human complement, mixes with patient red blood cell. If immunoglobulin or complement are on surface, Combs reagent will link it. Looks for anti-red blood cells antibodies in the patient serum using a panel of red cells with known surface antigens. Combine patient serum with cells from a panel of RBCs with known antigen. Add Combs reagent to this mixture. If anti-RBCs antigen are in serum, agglutination occur. Drug-related hemolysis, autoimmune hemolysis, hemolytic transfusion reaction, hemolytic disease of the newborn, autoimmune hemolysis, warm autoimmune hemolysis, and cold autoimmune hemolysis. Immune hemolysis, drug-related, immune complex mechanisms, kinidine, kinin, isoniazide, haptenic immune mechanism, penicillin, cephalosporin, true autoimmune mechanism, red cell surface protein, antibodies recognize altered protein, drug as foreign, antibodies bind to the altered protein, initiate process leading to hemolysis. Certain drugs appear to cause antibodies that react with antigen normally found on the RBC surface and do so even in the absence of the drug. Autoimmune hemolysis, hemolytic transfusion reaction caused by the recognition of foreign antigen on the transfused blood cells. Several types: immediate intravascular hemolysis, minutes due to performed antibodies, life-threatening; slow extravascular hemolysis, days, usually due to the repeat exposure to a foreign antigen to which there was a previous exposure, usually only mild symptoms; delayed sensitization, usually due to first exposure to foreign antigen, asymptomatic. Incompatible RBCs transfusion, the normal, slow extravascular hemolysis, and this is immediate intravascular hemolysis, delayed extravascular hemolysis. Immune hemolysis testing pre-transfusion, ABO, Rh type of both donor and recipient, antibody screen of donor recipient including indirect Combs, major cross match by same procedure, recipient serum donor red cells. Due to incompatibility between mother negative for an antigen, fetus father positive for that antigen, Rh incompatibility, ABO incompatibility, most common cause usually occur with second and later pregnancies, require maternal IgG antibodies versus RBC antigen in fetus. Can cause severe anemia in fetus with erythroblastosis and heart failure. Hyperbilirubinemia can lead to severe brain damage. Kernicterus is not promptly treated. HDN due to RH incompatibility can be almost totally prevented by administration of anti-RH D to RH negative mother after each pregnancy. Due to formation of autoantibodies that attack patient own RBCs, types characterized by ability of autoantibodies to fix complement site of RBCs destruction, often associated with either lymphoproliferative disease or collagen vascular diseases. Usually IgG antibodies fix complement only to level of C3 if at all immunoglobulin binding occurs at all temps. FC receptor FCC3b recognized by macrophages. Hemolysis primarily extravascular, 70% associated with other illness, responsive to steroid and splenectomy. Most common IgG mediated antibodies bind best at 30 degree or lower, fix entire complement cascade, leads to formation of membrane attack complex, which lead to RBC lysis in vasculature. Typically only complement found on cells, 90% associated with other illness, poorly responsive to steroid, splenectomy, responsive to plasmapheresis. Hemoglobinuria. Lab studies CBC and smear urine analysis, biochemical investigation for understanding the disease, serology for infections, mycoplasma pneumoniae or EBV or CMV, organ non-specific antibodies, anti-DNA, RNA, ENA, immunological standard AGT, poly-specific and monospecific red blood cell. Test the serum at 477 cytopenia, combination of AIHA salt. Discovery consists of seeing what everybody has seen and thinking what nobody has thought. Autoimmune and chronic neutropenia. According to the age, duration, infection in primary compared to secondary pathophysiology, the trigger is either by viral infection or immunization. Age, frequency, race, sex, mortality and morbidity, 3 to 30 months in Scottish, 1 in 100,000. No variation in ethnic group, more in girls, first in mild and limited than secondary. Accidental during febrile illness, no family history, local infection, no growth failure, chronic illness. The following are against AIN: severe illness, significant hepatosplenomegaly, life-threatening infection, and purpura. Differentiation. Other problem to the consider the possibility of pseudoneutropenia, human immunodeficient virus, absolute lymphopenia, isoimmune neutropenia, cyclic neutropenia, ethnic neutropenia, hypersplenism. Drug most common in adults, systemic autoimmune, transient viral infection. Complete blood count and smear. Test for neutrophil, ban FC gamma specific in secondary. Maternal serum for NA1, NA2 is in alloimmune. Bone marrow hypercellular and non-cellular lymphocytosis, maturation arrest, Ig quantitation, hypergamma globulinemia. Peripheral blood finding, normal RBCs and WBCs, condition, the finding and the condition. WBC's abnormalities: immature cell or increased mature lymphocyte in leukemias, marked dimension in plastic anemia, hypersegmentation in megaloblastic anemia, congenital thrombocytopenia, giant platelet. RBC's abnormalities: myelodysplasia, the immune thrombocytopenia, and this is the finding, the normal blood cell. And initial evaluation of patient with suspected immunothrombocytopenia: history, physical examination, bone marrow aspiration and biopsy in selected patient, laboratory testing. Condition that cause secondary immune thrombocytopenia: systemic lupus erythematosus, rheumatoid arthritis, thyroiditis, immune hemolytic anemia, lymphoproliferative disorder, chronic lymphocytic leukemia, lymphoma, viral infection, HIV infection, herpes zoster, Epstein-Barr virus infection, and cytomegalovirus infection. Drugs that can cause immune thrombocytopenia: quinidine and quinine, sulfonamides, cephalosporin, gold and levodopa, heparin, phenytoin. Aplastic anemia: stem cell defect defined by stem cell not formed in the vitro colonies, defended by stem cell not formed in the vitro, normalized hematobiosis, unlikely immune suppression, cyclosporin, stem cell repopulation, abnormal microenvironment, unlike in BMD. 3 cells line BMD microenvironment is that of the host. Abnormal regulatory cells, unlike in abundant stimulants, lymphocyte produce normal quantities of growth factor, immune suppression, activated lymphocyte after immune suppression. Paroxysmal nocturnal hemoglobinuria, paroxysmal nocturnal hemoglobinuria, clonal cell disorder, ongoing extravascular hemolysis, classical at night, testing acid hemolysis, sucrose hemolysis, CD59 negative product of PGA gene, acquired deficit of AGBI associated protein, including decay activating factor. Paroxysmal nocturnal hemoglobinuria: link a series GBI proteins, link a series of protein to outer leaf of cell membrane via phosphatidyl inositol bridge with membrane anchor via diglycerol bridge on X chromosome. Big A gene on X chromosome codes for synthesis of this bridge. Multiple defects known to cause lack of this bridge. Absence of decay accelerating factor lead to failure to inactivate complement, thereby to increase cell lysis. Diagnosis: sugar water test, Hamm's test, complement lysis sensitivity test, flow cytometry, CD55, CD59. Diagnosis: sugar water test, Hamm's test, complement lysis sensitivity test, flow cytometry, CD55, CD559, on RBCs, on granulocytes, CD66, and on monocytes, CD14. Pure red cell aplasia. Lab studies: basic studies rule out hemolysis and iron overload in acute BRCA, rule out B19, IM, mumps, viral hepatitis, and atypical mycoplasma. In acquired chronic form BRCA, rule out thymoma, CHA, SLE, autoimmune collagen, vascular and pregnancy. Congenital BRCA, fetal HB, ADA, folate and folate and B12 deficiency, genetic testing and megaloblastic. imaging studies and procedures. He who would learn to fly one day must first learn to stand and walk and run and climb. One can't fly into fly.